But before introduce Kristel, I want to recognize that those of us attending from Kingston are coming here together, situated on traditional Anishinaabe and Haudenosaunee territories. And I'm just thinking it is one of the coldest days of the year, but I personally love winter and just wanted to express my gratitude for the absolute beautiful snow to ski on, the ice that we can skate on. I think we might even be able to walk on the lake. And I love the crisp blue skies. And having been away for 3 months just really makes me recognize how beautiful Canada is to have the four seasons here. And just thank everyone for coming together over the next hour and just thinking about how our research here at HSPRI helps support principles of equity, diversity, and inclusion. And Kristel, I'm sinking into a deep introduction for you just because I just want
Oh, that's
everyone to know
okay.
how impressive you are. And they may not know your background. So I just wanted
That's
to give
very
this
kind.
opportunity. So Dr. Kristel Leung is an assistant professor of medicine in the Division of Gastroenterology at Queen's. Kristel has been here at HSPRI and ICS just over a year now, which is hard to believe. And we are just so fortunate to have her here at Queen's. She is extraordinarily impressive. She completed her med school at the University of British Columbia, UBC, in Vancouver, her internal medicine residency in Ottawa, Adult Gastroenterology fellowship in Toronto, followed by 2 years of advanced clinical and research fellowship in autoimmune liver disease. And excitedly and impressively, she completed her PhD this summer. Dr. Leung's clinical and research areas of interest are focused on rare and immune-mediated liver diseases and advancing cirrhosis care by leveraging multiple data sources, including clinical cohorts, health admin databases, and patient-reported outcomes. But she is here to present today on her work with complex rare diseases using health admin data, using primary sclerosing cholangitis as an exemplar. Kristel, I'll hand it over to you. Thank you.
Thank you, Catherine, for that really thorough and kind introduction. I really appreciate being here. Like Catherine said, I joined Queen's about 1 year ago in 2025 as a clinician researcher, and I've just been so blown away by the depth and the breadth of the research that is happening all around me here. So I'm very excited for the opportunity to speak to you today and share with you the work that comprised the majority of my PhD in clinepi and healthcare research that I completed mid last year. Okay. So my current research program combines and leverages multiple data sources to study rare liver disease epidemiology and improving decompensated cirrhosis care with more of an applied epi and implementation lens. But I've actually been lucky enough to experience different types of research during the course of my training. Back in undergrad, I was poking tadpole optic tectums with micropipettes and then literally watching neurons grow with a 2-photon microscope. And I switched gears completely during residency and then fellowship and then subsequently my PhD, focusing really in on clinical research in inflammatory bowel disease and then autoimmune liver diseases. And now I've been building up my research program, leveraging multiple data resources to study improving decompensated cirrhosis care, as well as continuing on some of the work of autoimmune and rare liver disease epidemiology. So today, the objectives I hope to leave with you are to be able to describe frequently encountered challenges faced in studying rare diseases, and to understand how health administrative data can be a tool for rare disease research, as well as to contextualize how we can use health administrative data for studying rare chronic diseases with heterogeneous trajectories and outcomes. So we'll start off with some background on the disease of interest, as well as some of the methodology, and then I will get into my two main research aims, followed by implications and next steps for this research. So we're going to focus on a condition called PSC for today's talk. PSC stands for primary sclerosing cholangitis. And what this complex name describes is when the immune system damages the bile ducts in the liver, which are involved in delivering bile, which is your body's natural detergents for digesting fats, amongst a whole host of other functions to the gut. So for my PhD, I chose to focus on PSC as they have some of the most unmet need compared to a lot of other chronic liver diseases with no cure or medication that's known to slow down progression of disease. That being said, my clinical and research work also spans other chronic liver diseases as well, which I won't be covering today. So back to PSC, it is a rare disease that primarily affects the medium to large bile ducts of the liver, as you can see here in this diagram on the left. There is a male predilection with about 7-3 in terms of males to females, and it's really characterized by bile duct scarring, obstruction, and infections secondary to the immune activation. And also, more than 70% have concurrent inflammatory bowel disease, or IBD, which involves immune-mediated damage to the colon and the small bowel. And on top of this, patients often experience significantly bothersome symptoms such as pruritus or itch, as well as fatigue. So ultimately, the inflammatory damage in PSC leads to significant scarring and fibrosis of the liver. This end-stage scarring, which is also called cirrhosis, is accompanied by complications such as decompensation and eventual liver failure. And this can manifest itself as confusion and bleeding, as well as recurrent hospitalizations and ultimately death unless a patient receives a life-saving transplant. And PSC patients also have a significantly increased risk for cancers, such as hepatocellular carcinoma, cholangiocarcinoma, gallbladder cancers, and pancreatic cancer, which fall under the umbrella of HPB cancers, or hepatopancreatobiliary cancers. And this risk can be up to 40 times more than the general population. As well, if they have IBD, they're also going to be at a 7-fold higher risk of getting colorectal cancer compared to the general population. So understandably, the risk of progression to any of these outcomes are of major concern, stress, and anxiety to patients, because it is incredibly difficult to know exactly who and when somebody might end up developing one of these outcomes. So just to bring it back a bit, so PSC is part of a family of autoimmune liver diseases, all of which constitute rare conditions, and they're all characterized by chronic immune-mediated inflammatory damage to different parts of the liver. And they're considered autoimmune in the sense that, yes, there is the immune system actually activated to attack the liver, but the etiology and the role of disease triggers are poorly understood. It's thought that they're arising from multiple causative factors rather than a single etiology with both genetics and environment at play. But it's important to recognize that these conditions are considered rare due to objectively a lower number of patients being diagnosed. And so I've just summarized the incidence and prevalence of each of the 3 most common autoimmune liver diseases in North America. And you can see these numbers are quite small in comparison to the number of patients who have diabetes, for example, or heart disease. But when you actually calculate the number of people living with these autoimmune liver diseases in North America, it would be equivalent to 9 Scotiabank arenas or 4 Sky Domes. And for a Kingston representation, this would be 27 concerts at the Slush Puppy Arena. So that just helps to contextualize, yes, it might be rare, but really we're still dealing with a large population of patients when you actually think about how this disease impacts our country. So studying rare liver diseases like PSC comes with complex challenges. Firstly, it's tough to create adequately powered patient cohorts. This can be overcome by international multi-center collaborations, but this does introduce variability due to differences in clinical practice as well as population differences. And secondly, these diseases weren't easily searchable on HealthMN data as they weren't coded until distinct entities until recently. So specifically, PSC didn't have a disease-specific ICD code until 2012 in Canada. Thirdly, in chronic progressive diseases like PSC, hospital-centric observational studies do not always capture the endpoints due to an extended disease trajectory over many years and the patients having fragmented care across multiple other hospitals. This diagram here just provides an example of how fragmented care can be for a patient living with PSC, living in Ontario. An episode of cholangitis, which is also infection of the bile ducts due to obstruction, can send a patient to one hospital to get endoscopic procedure to actually clear the obstruction and then fix the cholangitis. But they may be followed in another hospital for their liver specialists. And if they get sick and then decompensation leads them to get admitted, they might end up at a different hospital. But liver transplant is only available at 2 centers across the province of Ontario. So that's the only place they could actually get an in-person assessment. And then if they happen to develop cancer during the course of their illness, they may end up going to a specialized cancer institute for clinical trials, which might not be available at all hospitals in the region. And then lastly, if they have concurrent IBD, their care might take place at yet another hospital. So uniquely in Toronto, where I was doing my PhD, there is a vested interest in PSC as they have one of the largest patient cohorts in the world being followed at one clinic, together with a long-standing research program. And a lot of that is due to the Toronto Liver Centre being a quaternary care referral center, plus actually having that transplant program attached to it. So we took this cohort and springboarded this into a collaboration with ICS Queens, harnessing the power of healthcare administrative data in Ontario together with their detailed cohorts. Now, ICS, as this audience may be well versed with, is the independent prescribed entity funded by Ontario Ministry of Health and Long-Term Care. and it's authorized to use routinely collected healthcare administrative data with over 100 databases, including things like hospital discharge diagnoses, physician billings, deaths, cancer, and immigration. And these data sets are all linked for individuals as they encounter different aspects of Ontario's healthcare system using unique and coded identifiers. And this covers all 16 million individuals residing in the province of Ontario that are covered through OHIP. And it's comprehensive, it's population-based, and can examine healthcare encounters over time for individuals. And it can be a really powerful tool when used right to evaluate questions such as incidence of prevalence, disease trajectory, comorbidities, complications, as well as service utilization and evaluation. So what we did was we linked Toronto's cohort's clinical data to ICS, and then we used the Toronto cohort as well as the Kingston cohort of patients as a gold standard to test coding algorithms using the administrative data to ensure that we would be able to identify people across Ontario who have PSC, even if we don't have their entire clinical history or charts available at the provincial data level. And then thus, we can then evaluate a provincial population-based cohort of individuals with PSC and look at events that occur across the province during follow-up for these patients. We can also assess the demographic characteristics of this population, such as age and sex at diagnosis, socioeconomic status, risk factors for outcomes, and then also look at healthcare utilization after diagnosis and disease complications, as well as look at what is happening before diagnosis. So this brings me to our first objective, which was to prioritize evaluating the epidemiology of PSC, including incidence and prevalence and trends. And we also wanted to look at the characteristics and demographics of patients in Ontario with PSC. We also wanted to assess outcomes in Ontario for PSC patients and what were associated risk factors. So we specifically looked at the PSC IBD population, and a lot of this was due to limitations of PSC not having that disease-specific code until 2012. And this was informed by a study in the UK where they had tried to use a health administrative data algorithm to identify PSC patients. And they found that by coupling the PSC coding together with IBD coding, that was the most successful in terms of accurate identification. And they showed that if you only use the PSC codes, the accuracy is only 2%, versus if you couple the PSC and IBD codes together, the accuracy jumps up to 98%. So building off an algorithm used throughout Ontario for identifying IBD patients with the Ontario Crohn's and colitis cohort, we added the ICD codes for cholangitis, which is the K83.0 code, and then PSC once it became available from 2012 onward, which was the K83.00 code for defining this PSC IBD cohort. And so for the rest of this presentation, I am speaking specifically to patients with PSC IBD, which in theory we know should encompass the majority of PSC patients, at least over 70%. And actually in some studies, they say 99% of patients with PSC actually have IBD and it's just subclinical. Our inclusion and exclusion criteria are typical of a lot of ICS studies. So they had to have residency in Ontario with valid health card numbers. And then in terms of exclusion criteria, we did exclude anybody who had a transplant or death date on or prior to any use of the PSC codes, as well as if they had diagnostic codes for other rare genetic diseases, so hemochromatosis, alpha-1 antitrypsin deficiency, as well as Wilson disease. So for evaluating the algorithm performance, we had the two validation cores I mentioned. The first was from Kingston's Liver Clinic, where there were 11 patients with PSC out of 442 patients followed from May to August 2013. The second cohort was from Toronto with 363 large duct PSC IBD patients, along with 17,993 patients with non-PSC liver diseases. And we chose to focus on the large duct PSC IBD patients, as this cohort makes up the majority of clinically relevant PSC IBD. And these are also the ones who are more likely to present to hospital clinically rather than small duct PSC, which is more often found just spontaneously through other mechanisms. And so for the Kingston cohort, the algorithm performed really well with 100% positive predictive value, negative predictive value, and specificity with 82% sensitivity. Versus for the Toronto cohort, the algorithm performed with 85% positive predictive value, still great negative predictive value and specificity, but then sensitivity did drop down to 61%. And we suspect the difference in sensitivity is due to referral bias, again, because Toronto being the quaternary referral center with transplant attached to it, there may be a predisposition to pick up really early PSC and perhaps patients who might not have encountered the healthcare system as much as others. We did find that there was no differences in case pickup between urban or rural residents or sex, and there was a slight predisposition for picking up those who would go on to develop cirrhosis during follow-up. So I'm now going to present the epidemiological trends seen in the Ontario PSC-IBD cohort. And to contrast, I also present the epidemiological trends of IBD overall as a background comparator. And IBD itself is not considered a rare disease, and it's thought to actually affect about 1% of Canadians. It's a good background comparator given the PSC coding algorithm is based off of the IBD algorithm, as well as the close association of the majority of the PSC patients having concurrent IBD. So when we're looking at incidence, which is the new diagnosis of PSC-IBD with ICS data, the overall age and sex-adjusted incidence was 0.47 per 100,000 person years. And this is actually in the ballpark of other epidemiological studies across the world. And this is also seen to be slightly increasing over time with an annual percent change of 1.6%. This is not happening with incident IBD, where there's actually been an increase initially from that period from 2002 to 2009. And then there was this plateau that was seen between 2009 and 2014, followed by a drop in the last 4 years. Now, regarding the rising incidence in PSC-IBD, there's a big question of, is this unmasking of incidence versus a true rise? So incidence, as we know, it's essentially a diagnostic bias. So the more new cases of PSC being diagnosed might be due to the ability to detect PSC improving, and that can be affected by economic factors, increased awareness, improved diagnosis. A big part of diagnosing PSC is actually having a great quality MRI to actually be able to see the bile duct changes. A CT scan or an ultrasound might not actually be good enough to find those changes, especially when they're quite subtle and early in their disease. Conversely, is this because individuals have genetic susceptibility and now are just being exposed to something in the environment that's increasing the risk of disease? Going to look at the IBD incidence, that recent drop-off is thought to be due to what is considered a rebound back to natural incidence, as it was thought that there was a surge in diagnoses prior to the 2010s with increased awareness and IBD specialization. And now we're just kind of reaching back to what the actual incidence, the true incidence is. When we look at prevalence, both PSC-IBD and IBD prevalence is increasing. The overall prevalence for PSC-IBD is about 5.5 per 100,000 person years. If you look at the IBD prevalence closely, it seems to be leveling off in recent years, and it's thought that IBD will eventually reach this prevalence equilibrium phase where the IBD population is surviving longer and advancing in age, and that's approximating the incidence of IBD in terms of approximating mortality. When we look at the epidemiology differences between PSC-IBD versus IBD, it's actually quite relevant, particularly when you're considering what a gastroenterologist or a GI doctor may see in their practice. So for every 100 people living with IBD, there is potentially one person living with PSC-IBD in that group. And then for every 50 people newly diagnosed with IBD, there's one person with IBD that's also being newly diagnosed with PSC. So zooming in on the incident cohort, so we had 1,046 individuals that were newly diagnosed with PSC amongst the IBD cohort between 2002 to 2018, and we decided to follow them until 2021. The median age at PSC diagnosis is very reflective of also what's in the literature, so 45 years of age. Male sex was about 62%, and then in terms of IBD subtypes, 2/3 of them were ulcerative colitis, which primarily affects the colon, as opposed to Crohn's disease, which is typically both small bowel and colon. There was 158 liver transplants, so about 15% of the population that was studied had a liver transplant during the follow-up, and 312 deaths, or 30%. So with looking at the socioeconomic status for these patients, what we found was that there's a gradient of wealth in those being diagnosed with PSC-IBD favoring higher socioeconomic status. And this is seen looking at area level income quintile as well as area level material deprivation. And this is not as pronounced compared to IBD. And some of the thoughts about this was maybe it's related to actually where the individual is living. And so a part of it is because PSC is such a rare disease that you might actually require very specialized physicians and clinical care to be able to pick up these conditions. And so we know that already there's potentially a socioeconomic relationship between that association that we still have to figure out and tease apart from the data. But this actually goes against a lot of what we have seen with other autoimmune diseases, where typically it's actually flipped the other way around, with lower socioeconomic status being associated with more autoimmune diseases. We also decided to look at the PSC IBD diagnostic sequence as a major exposure of interest. And we found that the majority of patients were being diagnosed with IBD first, then PSC. And this was 83% of the cohort. What was most surprising was actually that the median time from IBD diagnosis to PSC was 7.7 years. Conversely, the time between PSC then IBD diagnosis was much shorter. And part of that is because once you have somebody who's diagnosed with PSC, you are going to start looking for IBD. Versus on the flip side, if you have IBD, because we know that, oh, PSC is rare, we might not necessarily be looking for PSC in an active manner. When we looked at differences between the two groups, so those with IBD, then PSC, were diagnosed at a later age, had a higher number of comorbidities, earned higher incomes, and also were more likely to be long-term residents or citizens and had less residential instability. And this gap in time between the IBD diagnosis followed by PSC is concerning, because this could be a crucial time for some patients who may actually have PSC but not know it, and thus be not getting the care that they're supposed to receive, and that can lead to significant consequences, which I'll get into. We also looked at the transplant-free survival for these patients, and transplant-free survival is the common sort of outcome that we look at in the liver research space. And so the overall median transplant-free survival from PSC diagnosis in the incident cohort was 13.6 years. But when we looked at transplant-free survival by PSC IBD diagnostic sequence, patients who are diagnosed with IBD then PSC have worse transplant-free survival with a hazard ratio of 1.73. And so this is key, is from a hepatologist's point of view, this can affect how you counsel the patient and perhaps how you adjust their management plan, keeping their risk in mind in terms of outcomes. So you might ask, why is this happening? It could be that there is subclinical or undiagnosed PSC in those who are diagnosed with IBD for a long time and then PSC. So the patients are existing with some period of time with accumulated damage and unknown cancer risk, and that by the time they present for medical attention, their disease is actually much more advanced. Another way of looking at it with a statistic lens is that could this be a form of sort of lead time bias, and choosing PSC as a start time for those with IBD, then PSC is introducing this bias because you're not accounting for the disease process that's happening before the PSC is actually formally diagnosed. When we used a multivariable model for transplant-free survival, even when adjusting for age at PSC diagnosis, sex, and comorbidity burden, the timing of IBD diagnosis was still relevant, with a hazard ratio of 1.34. We then tried to tease apart exactly which of the outcomes was actually factoring in. Was it death or was it transplant that was actually really pushing this outcome? And we found that the diagnostic sequence most significantly associated with death and not so much transplant. And really, it was a 2.73-fold higher risk of death if IBD is diagnosed before PSC. Oops. I don't know what happened. Okay, there we go. So for the statistics-minded members in the audience, as a sensitivity analysis to try to understand this, we did try breaking up the coexistence of IBD's impact on outcomes after PSC diagnosis by breaking it into IBD duration before PSC, as well as a time-dependent variable for PSC-IBD coexistence. And we found that the duration of IBD prior to PSC was driving increased risk of transplant or death per year increase. Conversely, if you had coexistent diagnosis of PSC-IBD, that was protective. And this makes clinical sense, as not knowing you have PSC may mean you're not getting proper evaluation for progressive liver disease and ultimately a shorter time to progressing to transplant, death, or cancers. But once one is actually diagnosed with PSC-IBD, there are guidelines that say that you should be getting proper evaluations, such as regular MRIs and regular screening for colon cancer and HPV cancers, and the risk of these outcomes may be attenuated by actually receiving proper care. And this is also supported by various other studies where IBD duration pre-PSC diagnosis has been associated with cholangiocarcinoma or bile duct cancer, which is the most common type of cancer seen amongst PSC patients. So the next question we wanted to ask was, what is the mortality burden in PSC-IBD patients versus the IBD population? And what are the causes of death? So using the RPDB and ORGD databases at ICS, we examined deaths and causes of death in detail. And we found that of the third of patients with PSC-IBD who were deceased by the end of 2021, the majority of them were dying at around a median age of 65 years of age, compared to the IBD population, which only experienced 8.6% mortality and a median age of death of 74. And so that's a 9-year median age difference for PSC-IBD patients compared to their IBD counterparts. And then when you're looking at the cause of death, the mortality being experienced by PSC-IBD patients is being primarily driven by their liver disease and HPV malignancy, while IBD patients are mainly dying from heart and lung disease, similar to the general population. So as we know that HPV cancers and colorectal cancers are the two groups of patients that are commonly seen amongst PSC-IBD, our objective 2 decided to focus in on evaluating the burden of these cancers seen in this population. So this is just a survival curve for individuals with PSC who reach particular states of their disease during their course of illness. I just want to highlight here that individuals who end up with either colon cancer or HPV cancers have the worst survival compared to other individuals with PSC-IBD. And HPV cancer is particularly bad, with a sharp drop-off in terms of survival within the first 2 to 3 years after the HPV cancer diagnosis. So for this objective, we wanted to look at the sub-cohort of PSC-IBD individuals where we're able to track the entire course of both PSC and IBD within the data timeframes available at ICS. And it's not just looking back to 1991, for which we had for the IBD patients, but it had to be from 2002 onward because of ICD codes, and then also for OHIP codes, and so that we could actually look at the entire time frame and not have too much missingness in terms of what was going on during the trajectory of illness. And so that necessitated that individuals had to be diagnosed with both PSC and IBD between 2002 and 2018 to be included in this subset. So that ended up cutting the cohort down from 1,046 down to 476. We then followed them until 2021. The demographics there are pretty similar to what we had before, except that the median follow-up time was slightly shorter and the median age at PSC and IBD diagnosis was slightly younger. So we first looked at the cancers being diagnosed in this subset cohort, and you can see here from the proportions, cholangiocarcinoma was the most common type of HPV cancer. What I want to emphasize with this table is just the age that these cancers are being diagnosed, with the median age being around people in their 40s and 50s. And so you can imagine what implications this has on an individual in terms of their life, including work and financial situation, as well as the emotional burden that is placed upon them. And particularly for cholangiocarcinoma, as I've emphasized, the prognosis is dismal with a high mortality rate within 5 years. The other part that is quite disconcerting is that the median time from PSC diagnosis being flagged in ICS to a diagnosis of HPV cancer was about 0.3 years or 3.6 months. And this is actually a well-documented phenomenon in the literature, with the majority of HPV cancers amongst PSC being diagnosed within the first year of PSC diagnosis. And this has been replicated in the UK, the Netherlands, in Asia. And so this is a very concerning finding that we keep seeing across the board. And this is again alluding to the idea that we might be diagnosing PSC patients too late. Versus if you're looking at the timeline from IBD diagnosis, HPV cancer diagnoses are much more spread out in time from their IBD diagnosis, with a median of about 7.3 years. And so when we talk to our PSC patients, they are often worried about getting the diagnosis of PSC first and foremost, because they've been on the internet and they've read things. And so there was this very interesting study that came out in 2022 from Duke University that evaluated PSC patient perceptions of cancer risk. And so they asked participants questions about what they perceived their risk of cancer was associated with their PSC, using multiple choice questions with different cutoffs for different levels of risk. And they found that a quarter of them actually believed 1 year risk of getting cholangiocarcinoma was over 20%. And then there was a fifth that actually perceived no risk of cholangiocarcinoma within 1 year. So very, very wide in terms of just the perception of what that cancer risk could be. And then similarly for colorectal cancer risk, 33% estimated a lifetime risk of over 40%. So thus, we wanted to ask that important question of how likely is a person with PSC-IBD going to develop HPV cancer versus staying cancer-free, but progressing down an alternative pathway to actually ending up with cancer-free, liver transplant or death. So actually having a decompensation and then progressing to transplant and death, but without cancer. So we looked at this with a competing risk model with time zero measured relative to whichever PSC or IBD diagnosis came first, as well as if we just started time zero at PSC diagnosis. And what we found is that cancers or cancer-related deaths were much less common at the 5-year, 10-year, and 15-year mark, regardless of sex, compared to the cumulative probability of progressing to cancer-free liver transplant or death, which was much higher. But even then, if we may perceive the percent cumulative incidence to be smaller for HPV cancers, it's still concerning. A 5% cumulative incidence of HPV cancer at 10 years is not small. And then in contrast, a 15 to 20% chance of experiencing liver transplant or death at 10 years is still quite concerning. So one of the questions as well that is in this space is this controversy with regards to the risk of cancer, with regards to having surgeries such as cystectomy or gallbladder removal, or having part of your colon removed or colectomy, and how that will affect your risk of disease progression to transplant, death, or cancer. And the reality of this is actually, it's quite complicated. And we attempted to answer this using a multi-state model here, where mathematically the models look at the trajectories of multiple individuals, and from the combined pathways of all these individuals describes how frequent and then how fast individuals may transition through a particular state to another. So for example, if I can just take you through this diagram, starting from the left, someone can go from event-free disease directly to transplant, or they could go from event-free disease to colon cancer, to requiring a colectomy because of their colon cancer, to transplant, and then to death, or just any of the combinations that you see here. So as you can see, this is quite complex, but this is the reality of PSC, as well as a lot of other conditions that we know about. And it's really important to consider the heterogeneity of diseases with multiple different patient healthcare journeys when you're trying to ask these questions. And so by mapping out the trajectory of all those 476 patients, we found that there was a 54% probability of remaining event-free at 10 years. Conversely, 13% experienced at least 3 events during the course of follow-up. So using this time homogeneous Markov multi-state model also allows us to actually map the course for these individuals by dividing the follow-up time into predefined states, and then tracking the individuals along a timeline anchored by the index date, which for this case, we use the earliest of the PSC or IBD diagnosis. And then using the multi-state model, we can compare transition rates, which is where we can look at how fast somebody is progressing from one state to another, and then calculate a ratio or a transition intensity ratio, where we're looking at it relative to something else. So here, our reference state was actually event-free PSC IBD. When we looked at people who had a colectomy versus those with event-free PSC IBD, reaching the state of being post-colectomy was associated with a 3-fold increased rate of progressing to future death, but not transplant or cancer, again, relative to those with event-free PSC IBD. Cholecystectomy was also associated with a 3-fold increased rate of death compared to event-free PSC IBD, but nothing else was noted to be significant between the two groups. What's important to recognize from the clinical perspective here is that these higher mortality rates observed after these surgeries are likely related to the underlying disease processes that motivated surgical intervention, such as malignancy or refractory IBD, or concerns for symptoms, for gallbladder surgery particularly, rather than the surgery itself and a post-op complication. And so that was something that was really important to drill home when we decided to write this paper up, because it can be quite misconstrued if somebody's thinking, oh, like, I'm not going to get a surgery because death could actually happen. Well, no, you actually are indicated to have the surgery, and it's actually the reason why that you might have an increased risk of mortality is actually the reason why you need that surgery. So explaining that was something that we really wanted to be super clear on. And then HPV cancer, understandably, was noted to be significantly associated with accelerated progression to transplant or death. So another useful tool that comes out of this multi-state model is the ability to tailor probabilities of future events based on the current state of an individual, with predictions of probabilities at various time points. So for example, figure A here shows what the probability is of different events occurring by the 5-year mark and the 10-year mark for someone who is currently event-free. And then figure B here shows what the 5-year probability is for other states to transition to different events. And I've just come to love multi-state models for their usefulness in understanding how complex and variable disease trajectories like PSC can be, and also how it can actually be used to really inform individual management as well as personalized patient counseling. So to summarize, in terms of study implications, the two objectives covered thus far found that PSC-IBD epidemiology in Ontario is demonstrating differences from IBD, suggesting that these are distinct disease processes as well as different disease courses. Cancer, particularly HPV cancer, continues to carry high morbidity and mortality amongst PSC-IBD patients. And being post-op from cholecystectomy and colectomy is associated with an increased progression rate to death, likely related to the surgical indication rather than the surgery itself. And there's still unmet need in terms of early identification of PSC amongst IBD patients and then HPV cancers in PSC. So where do we go from here? So we still know that PSC is underdiagnosed and underrecognized. We found that 83% were diagnosed with IBD than PSC. And so there's a question of, is there a missed opportunity here to identify PSC disease early and hence intervene? And so the hypothesis is that if we identify those with PSC earlier, we can initiate screening for cancers earlier and potentially improve cancer-related mortality. That being said, there's still this concern that ultimately people who end up with transplant for their PSC, there's still about a 30% risk of actually having recurrent PSC post-transplant. And that's also another space that we're still trying to understand underlying pathophysiology and test therapeutics. So it's not a perfect sort of mechanism to identify PSC, screen their cancers, and get them to transplant. So that still needs to be really worked out. And so in trying to look at some of the healthcare utilization, one of the beauties of ICS is that you can look pre-PSC diagnosis. And so this is some of the prelim data that we had just examining the different groups in terms of things like physician visits, emerge visits, and inpatient visits, and then also their biochemistry. So IBD then PSC is here in red, and then blue is the patients who are PSC then IBD. And this is the time frame leading up to PSC diagnosis. And so you can see here on the left, this is for GI visits, and on the right here, it's non-GI specialist visits. And for the IBD group, understandably, because they're seeing their IBD doctors, they are seeing GI specialists in the year leading up to it, their PSC diagnosis. And then when you look at the patients who are just seeing the non-GI specialists, that is also still the same sort of pattern for the IBD then PSC patients. So it's not like they're not seeing people, it's that they are, but potentially PSC is just not coming up on the radar. We then looked at same-day surgery or emerge visits as well as inpatient visits. So inpatients is on the left, and then emerge and same-day surgery is on the right. And we found that here, really, these are not patients who are presenting in the 5 years before for anything really to hospitals or emerge visits. They are actually being seen or not only being seen really in that year before they're actually being diagnosed with PSC. And it's not worse between the two groups. And then we also looked at ultrasounds and MRI to see whether or not we just weren't picking it up because they weren't presenting to hospital. Because as we know with ICS, a lot of the coding is very reliant on actually having inpatient or hospital encounters. But here again, like we're not seeing a huge difference in terms of the number of ultrasounds or MRIs being done. And as I said earlier, like it's really important actually for PSC to be diagnosed with MRIs. And once actually you're diagnosed with PSC, you should be getting annual MRIs. But we're not seeing this. That means that PSC is actually really only being diagnosed when we're seeing the ICD code show up in ICS. And that also gave me reassurance that, you know, our cohort actually makes sense in terms of we're not having this huge lag time between when the clinical diagnosis of PSC is and when the administrative sort of incidence is for PSC. And then getting into the biochemistry. So alkaline phosphatase is the one liver enzyme test that tends to go up quite frequently when there's bile duct damage going on. And it's interesting here because the patients who have IBD then PSC, the alk phos is actually quite normal leading up to sort of the -2, -1 year mark. Yes, there is a spread in the groups by year, but then it's the PSC than IBD patients that actually have more of a jump in their alkaline phosphatase leading up to their PSC diagnosis. And this is similarly reflected in total bilirubin. So total bilirubin is the blood test that goes up when there's blockage of the bile tree and leading to actually some of that bilirubin, which is the natural byproduct of red blood cells that's processed by the liver. It's spilling up into the blood because it can't actually be excreted from the liver. That's how the bilirubin goes up in the blood. And we can see again here that yes, the bilirubin is going up more so for the IBD than PSC patients, but it's much higher in comparison to the PSC than IBD patients. And part of that might be just that their disease is much more advanced. We know that with bilirubin, it's actually quite a prognostic factor in terms of how advanced their fibrosis is for their liver. So there's some digging that we need to do in here. And then similarly, the aspartate aminotransferase and the alanine aminotransferases are different liver enzymes that are related more so to the parenchymal tissue outside the bile ducts in the liver. But you can also see here similarly that the patients who have IBD than PSC have a slightly lower rise in their AST/ALT compared to those who have PSC than IBD. So this is all to say, like, there are some signals that we're seeing in terms of the biochemistry, in terms of their healthcare utilization. And so there is potentially an opportunity here to see if we can try to identify these PSC patients earlier. Now, there are some hiccups with this, especially with biochemistry, because we really don't have all the biochemistry for every individual pre sort of 2010. But after this, and especially nowadays, like I think there is actually quite a bit of promise to try to see and investigate whether or not there are some risk factors that we can see to detect amongst the IBD patients whether or not they have PSC. So more work to come along in this space. So with that, I'd like to thank these organizations and groups for their support in my work and training, as well as these particular individuals, and shout out to Jen and Wenbin for their mentorship, teaching, and guidance and collaboration with this work. My graduate studies were supported by the CHR Vanier Graduate Award, as well as PSC Partners Canada, and then donors through the UHN Foundation. And I'd like to thank you for your attention, and I'm happy to open the floor to questions.
Well, that's impressive, Kristel. And I just appreciated how much work you must have put into the slides to visualize not just the data, but even just trying to make the data have an impact in terms of, thinking about how many people are at Slush Puppy, for instance. I love the thought of doing that. That's wonderful. Nora, I'm going to pass it over to you. I've got a few questions, but I'm sure lots of people have much better ones than I.
I'm sure that's not true, but I'm sure there's a lot of questions. It was very exciting. There was so much information, and it raised more questions than you or the group has time to discuss today. So I guess I just have to choose one, Kristel. And then if we see you at a social gathering later today, well, then beware.
We'll see. I'll try to come in after clinic if I can, but we'll try.
So I guess what really strikes me is the difference in diagnosis from, whether you're diagnosed with IBD first or whether you're diagnosed with this rare liver disease first. And some of the differences that they imply, but were not directly measured. And so I guess my question is just from a procedural or assessment point of view, you might have answered this towards the end. Are there any objective tests that conclusively will say that you have this rare liver disease or you don't? Or is it a series of tests? And the reason why I ask is the next step to kind of, do you have enough data to push for among people with IBD to get screened for this disease?
That's a great question, Nora. So I didn't cover this, but essentially in the diagnosis of PSC, one of the first signs is that you have an elevation in the liver biochemistry. And there's a typical pattern with the ALP and the bilirubin being a little bit more elevated than the AST and ALT. And then once that is there, that's more like a screening test, if I were to say it, but it's not specific to PSC. It's like very common to see that in a lot of other conditions as well, including just bile duct obstruction from getting a stone in your bile ducts. And so the best test would be to having a high resolution MRI. And it's not just any MRI. It's called an MRCP, which is a fancy word to just describe that they use special contrast to look at those bile ducts. And then on top of that too, then you've got to have like the clinical sort of evaluation. So it's not a simple blood test to be able to find it. I've taken these results to my IBD colleagues. So Amanda Retrudo and Eric Benjamin actually are pediatric gastroenterologists with a specialization in IBD, as well as Amanda has actually done some pediatric PSC IBD research.
Yeah.
And then
And did
looking
you
at
say
this
Eric
question,
Benjamin?
yes.
Yes. Okay. Yeah, I know
Yeah.
him.
And so like in talking with them, they're also surprised by like how big that gap is for the IBD than PSC. And so there is some talk about, you know, should we be doing annual liver enzymes in IBD patients to look for PSC? That would be a very low cost, sort of quick, easy way to find these patients potentially and perhaps flag. And it's not going to be the majority, or it could be, I should say that it doesn't actually cover everybody who ends up presenting with PSC, because we've certainly had cases in Toronto where somebody just presents with normal liver enzymes and it's just found that they have PSC on MRI. So there are those cases.
So that's
as
the
well.
challenge, is like the false
Mhm.
safety created by a screening test that might not necessarily be sensitive for that problem, especially
Yeah.
from the, non-quaternary care clinician point of view. And
Yeah,
so,
absolutely.
yeah, so it's a really interesting issue, and especially given that the gold standard for diagnosis is going to be not just an MRI, but an MRI with contrast. So,
Mhm.
yeah, I don't envy you that one, and very exciting and interesting. Wow, lots of implications. I'll open up the floor to other people.
Thanks, Nerd.
No, there's a group of people in one room, so we can't see everybody. I don't know. I see Wenbin there. Well, if other people don't have a question and you can still be thinking, what really struck me, Kristel, was, and again, you highlighted it, that this was a group of people that were wealthier and higher socioeconomic status, which again, you mentioned you don't often see this a reversal. And you
Mhm.
alluded to environmental risks potentially. Like, I'd be curious to think about what that might look like, to Nora's point, like what kind of screening or thoughts, what that would even be.
Mhm. Yeah, that's like the $1 million question in
Mm.
terms of environmental studies. So when they've looked at the balance between like how much of it is genetic susceptibility versus environment, they think that actually for PSC, it's less than 10% genetics,
Mm.
which is actually something that they see a lot in all these autoimmune conditions that are out there. That environmental piece is one of the toughest things to try to piece apart. And I often use this analogy in clinic. I ask people, like, do you remember what you ate for lunch last week, this day,
Mm.
last week? I'm like, I don't know. And then you think
Right.
about, okay, how many exposures must somebody have had in their lifetime to actually have been the event or the accumulation of events to predispose somebody to develop PSC? And like in my mind, like the thing that really strikes me about PSC being slightly different from other diseases is just how much fibrosis, like the scar
Mm.
tissue, actually forms. And in the IBD space, there's been a lot of work looking at the microbiome, the interaction with food and processed foods. And then now there's starting to be a little bit of a foray into microplastics and how that
Interesting.
might actually inform sort of who or somebody else might be affected by that, how it affects the microbiome and how it sort of triggers the immune system. And there's some sort of studies coming out from, I think, Asia mostly, that are looking at microplastics in the gut and then microplastics in the liver. But it's very hard to really kind of draw that causal inference line between microplastics, people being exposed to it more, and then having this autoimmune disease, recognizing that microplastics are ubiquitous in our environment. To that point about the socioeconomic status, so some of the
Mm.
highest prevalences of PSC and IBD exist in Northern Europe. So Finland, Sweden, Denmark. And we know that those countries also have some of the highest, like, I forget what the acronym is, but for in terms of their economics, like their economic
Mm.
status is really quite well
Yeah.
overall from a
Yeah.
country perspective. So there's that question too that came up, is like, well, like maybe that's associated with something about their lifestyle
Mm.
related to having higher socioeconomic status, but maybe it's something with that lifestyle how that could interact with it. But that's a whole nother realm that's much more exploratory. And I think there's a lot of really smart scientists out there who are trying to answer this question. I'm very happy looking at seeing if we can see those patterns, and I'm hoping that in the future that there can be some collaboration between the basic scientists that are working on this work and trying to show like geographically does it actually correlate as well.
Really interesting. Thank you. Jen.
Thanks, Kristel. I'm in the car, so I just have my screen up. But thanks again. I always love hearing you present your work, and I just really want to congratulate you on your ability to objectively describe what we've been seeing as clinicians. Like we all know as liver physicians, when we have a patient with PSC and IBD, we're worried, not necessarily because we had the objective evidence to say, but you've really been able to use all of your training and access to these databases to really actually quantify that. And I think your multi-state model is just so interesting, especially it's just very clinically relevant because that's something that you can discuss with patients. And then again, I think it's what clinicians see, but you can't really just quantify that apart from your gestalt. So again, I just want to congratulate you, and I'm just really looking forward to seeing where else you can take this, because as we all know, using these large databases is one of the best ways we're able to understand rare diseases a little bit more.
Thank you.
Thanks, Jen. Sahar.
Thanks, Kristel. That was awesome. I didn't know so much about what you've done so far, so I'm like really excited to hear all about it. I have a suggestion for you. Have you thought about using like a target trial design to actually evaluate screening? So you do have like quite a number of people who are getting tested with certain biomarkers over a period of time. And then I'm sure you have lots of people who haven't as well for whatever reason. Is there any way you could use sort of those causal inference models to evaluate screening? And you know what my interests are.
Yes, I would love to. I would honestly really love to. That is something that I think would be really helpful to try to push the case for actually looking in the IBD population. The other thing I forgot to mention is that there is a lot of silos that exist within medicine, and even particularly within the GI sort of specialty. The IBD doctors tend to be in their own silo, and then hepatologists tend to be in their own silo. In Kingston, I think like I've just experienced such collaboration. Like we have the same rounds, we have like the same patients, but in Toronto, like the IBD doctors were across the street, and even though they were just across the street, they had a different EMR system that didn't connect with us. And so there's some barriers that I think we need to overcome in order to actually get buy-in, but definitely a target trial demonstrating that you can actually show benefit. I think that would be really crucial to sort of driving home this point that we really need to look for these patients. Even if it's a rare condition, like we really need to look for this and try to address it early as possible.
Let me know.
I will probably circle back to you and say, hey, let's collaborate. Let's do this.
I feel like this is a project starting right now. That's great.
Right.
See, it's 5:02, Kristel. I was just going to say, I think you have to go, so we're going to cut this right off right now. That was truly impressive, so comprehensive, and just like congratulations, and can't wait to see the next stage. It's really impressive. Thanks, everybody.
Thank you. All right. Thanks, everyone.